Okay, good morning again. So I'm Dr. Rim from Samsung Medical Center, Seoul, Korea. It is a great honor to be invited to faculty for this ACTA training workshop with cooperation with Bangladesh Society of Radiology and Imaging and Bangladesh Society of Vascular and Interventional Radiology. Again, I'd like to thank the Professor Hwang Wang and Professor Vishuvat for preparing this nice symposium. I think you can enjoy the real basic of ablation today. The curative treatment option is always surgery, especially for malignant tumor. However, many patients with cancer cannot be treated really curative resection. So local regional treatment is a good alternative. There are many organs can be applied with ablation. As we know well, liver is the most common organ, the more than 80% in the world, and also lung and kidney and musculoskeletal. And thyroid and uterus is a good organ applied. What about the energy source? As I listened from the Professor Hwang Wang's audio lectures, there are many tools, including thermal and mechanical and even chemical. Thermal ablation, radiofrequency, and microwave ablation is the most common energy source. And also we can use the irreversible electroporation and even focused ultrasound, histotripsy. I would say our mission of ablation research is very similar to that of postman. It is very important to deliver right energy to the right place at correct location using image guidance. Maybe Dr. Lin will cover at following lectures. Shall we start with the liver ablation? In the next 18 minutes, I'd like to cover 3 questions. First, where are we now? Second, what still matters? Third, what comes next? Shall we start with the first question? Where are we now? In other words, what is the current position of ablation in treatment guidelines? There are so many guidelines proposed. Before answering to this question, I'd like to introduce my old story. In 2018, my sabbatical leave for 1 month. At the time, I had a chance to meet these 3 senior doctors who developed local regional treatment for the first time in the world. And they are all alive and very healthy, very actively working. So please remember, ACTA is the birthplace of ablation. I think maybe 20 years later, the new technique can be developed in Bangladesh, I hope. Thanks to the many works by ACTA members, according to the Dr. Liang's recent review paper, more than almost 50% of publication were published from Asian country, the founding country of ACTA. This is 2 famous representative papers from Japan and Korea, our center. As you can see, 5-year survival rate is almost 60%, recurrence-free survival rate is 30%, really, which was the best at the time. Recently, we revised the 10-year outcome for single HCC. As you can see, the survival rate at 10 years, 74%, remarkably improved compared to 10 years ago, thanks to the technical advancement. What about the surgery versus ablation? Really long-standing debate in all the conference. But nowadays, most physicians accept this kind of summary. Local tumor control is definitely surgery is better, but overall survival quite similar. What about cost effectiveness? Definitely, ablation is much cheaper than surgical resection. This is the famous recent randomized control study from Japan, from 48 institutions. They compared surgery versus ablation for small HCC. But as you can see, surprisingly, overall survival and even recurrence-free survival, there was no significant difference between curative surgical resection versus percutaneous ablation. From that study, and also non-randomized core trial shows comparable result between surgery and ablation. After this randomized controlled trial, we can say, even if surgically resectable, we can consider ablation first. What about ablation in the treatment guidelines? As we know well, liver transplantation, resection, ablation are the treatment of choice when available and feasible because of their curative potential. This is the summary of ablation in the all treatment guidelines. As you can see, lead ablation is accepted one of definite curative option for very early and early stage HCC. In our society, Korean Liver Cancer Association and National Cancer Center also revised the fourth revision of HCC treatment guideline. As you can see, ablation is clearly positioned for best option for the HCC, supported by level A evidence. In recent revised version 2022, ablation finally survived as a curative treatment option for very early and early stage HCC. Right now, we are in the old treatment guidelines based on the evidence that we have made together since 20 years. Let's move on to the second question. What still matters for successful ablation? I would say first, tumor size, tumor location, tumor biology still matter for successful ablation. We should remember this item one by one. What about size? Too small or too large is always a problem. Thanks to the technical advancement of imaging technology and surveillance, the tumor size detected is getting smaller. However, we have many solutions, including for small tumor, we can use fusion and contrast nasal ultrasound. For larger tumor, we can use a strong weapon, microwave, and or combined treatment with TACE. We have many good friends to support successful ablation. Location is really critical because ablation is a local treatment. For example, subcapsular, perivascular, periorgan tumor. Many physicians concerned about this location. However, if you look at the recent paper regarding tumor location, there is no significant difference in overall survival in terms of tumor location, because we already understand the technical difficulty and applied assistant technique and modify ablation protocol. For example, for subcapsular tumor, we should use at least 2 electrodes or at least 2 overlapping ablation. What about perivascular tumor? Perivascular tumor has a broad spectrum because there is a contradictory factor, heat sink effect versus vascular complication, including infarction. And also, many studies dealing the perivascular tumor is very complicated. We should be carefully accepted because the spectrum is quite broad. However, we have many solutions for perivascular tumor. To overcome heat sink effect, we can use strong microwave ablation, and also we can use no-touch radiofrequency ablation, or we can combine with TACE or ethanol ablation. There are many solutions you can choose. The most important factor for dangerous ablation is the periorgan. There are many organs, diaphragm, especially bowel, colon, but artificial ascites fluid is a universal assistant technique, as you know well. So fusion, artificial fluid, and contrast nasal assistant ablation can provide safety. The last factor is the biology. More curative approach is necessary for aggressive tumors, such as a high tumor marker and microvascular invasion on imaging study, or LLM feature on imaging study. If you find this kind of factor, we should be careful to select just ablation. This is our study. The tumor with microvascular invasion finding shows the worst outcome, and also LLM feature shows the worst outcome compared to ordinary LL4 or LL5. What about the energy source? I think the Korean doctors are still most resistant to microwave ablation compared to radiofrequency ablation. There are two reasons. Please think about it. The one reason is microwave ablation still no survival gain at the moment, and RF ablation is still evolving. Definitely, I agree. Microwave ablation is a stronger weapon than RFA. My old friend Fred Lee is one of the developer for one microwave system. He told me, "Oh, you have to switch," but there is no sufficient evidence showing the real survival benefit, even the randomized controlled trial at the moment. The excellent researchers are developing the multiple no-touch RF ablation technique, which is quite ideal approach without touching the tumor and make the enough ablative margin. The recent couple of studies from their group shows the really best outcome, which is comparable to the best outcome of microwave ablation so far. Recently, their group reported the no-touch radiofrequency ablation guideline in Korean Journal of Radiology. Maybe you can take a reference. It is very useful especially for beginners. What about the current solution for this kind of aggressive tumor? Definitely, careful selection is the simple, easiest way. We should exclude this kind of tumor for just a simple conventional ablation. We should consider alternative, more curative option, surgical resection and no-touch RFA, and combined with TACE. Still, there are a couple of things still matter, but we have many novel assistant technique to overcome the kind of ablation. Okay, what is the next? What comes next? There are many kinds of assistant software for accurate guiding and accurate assessment of ablation, but the many physicians does not use this kind of software as we initially expected, and many more the software are based on CT guidance. Cryoablation and ILE is a really potential good energy source, but ILE is expensive. Cryoablation requires a long procedure time. That's the problem. I'd like to introduce the final new kids on the block on ablation, the histotripsy. Histotripsy is a focused ultrasound technique resulting in mechanical tissue fragmentation. Currently, one device on the clinical trial. I am looking forward to seeing the new energy source. What about low-level ablation in the area of immunotherapy? There are many kinds of studies already proven immune reaction after ablation, and also there are many kinds of trial, local regional treatment combined with immunotherapy, and also there are several adjuvant immunotherapy after local regional treatment. So still, most studies are underway. If validated, these treatment schemes will need adequate patient selection in order to maximize the result. So we will see, we can taste the real one of these oak batters near the future. What about the lung ablation? Based on the many treatment guidelines, the ablation is accepted as a safe and effective treatment with minimal complication and survival outcomes compared to radiation and sublobar resection. And NCCN guideline also the option for the asymptomatic solitary metachronous tumors. What about the indication for lung metastasis from colon? NCCN guideline and ESMO guideline and SIR guideline, they accepted ablation technique may be considered alone or in conjunction with the resection for even resectability. In lung-only disease or oligometastatic disease, the thermal ablation may be considered if resection is limited by comorbidity. This is one comparative study. As you can see, there was no significant difference between ablation and surgery. They showed a similar overall survival and progression survival rate. What about the kidney? Kidney is also a good organ to apply the ablation. Currently, to my feeling, the cryoablation is more preferred compared to thermal ablation. Regarding oncologic outcomes and functional outcomes, cryoablation is not inferior to partial nephrectomy. Regarding the quality of life outcomes, cryoablation is superior to partial nephrectomy. So finally, thyroid. Thyroid is a really hot field the many physicians and endocrinologists has an interest to start ablation. This is a summary of long-term clinical outcome for benign thyroid tumor. As you can see, the regrowth rate is less than just 5%. That means a really great tool to reduce the tumor volume using the thermal ablation. And recently they extended to malignant thyroid tumor, or recurrent thyroid cancer lymph node. As you can see, the outcome comparing the surgery is quite promising. The almost 90% recurrence-free survival after the ablation. And finally, the recent study, the primary thyroid microcystic papillary carcinoma, as you can see, there was no local tumor recurrence after the ablation. This is quite safe and complete curative treatment option. Maybe you can consider later. Okay, for almost 40 years, ablation have been too local. So I think it's time to move beyond local to precise and optimal ablation and liver conserving ablation. Novel is definitely beautiful, but please remember the root. Basic, beyond the novel, is much more important. Let me conclude my talk. So ablation is curative treatment option for small HCC treatment guidelines. Novel technique is necessary for better outcome, but basic is more important. So if you have any question or if you need my help, please contact me with under the email address. Thank you very much. Dhanyavad.
Thank you, Professor Lee, for sharing your in-depth knowledge and an interesting presentation.